Right, so the trigeminal nerve, this is one of the cranial nerves that you got to know out of the 12 cranial nerves. And it's called trigeminal because, well, tri means three, so it has three divisions, which we'll talk about now. So the anatomy of the trigeminal nerve, right, like, for example, the facial nerve and the abducens nerve, this is found in the pons. So remember, all cranial nerves lie in the brainstem. So if you know the three structures of the brainstem, which you should know by now, it's the midbrain, pons, and medulla oblongata. The upper cranial nerves lie in the midbrain, the middle cranial nerves lie in the pons, and the lower cranial nerves lie somewhere along the medulla oblongata. So because this is cranial nerve number 5, it's like a middle number of out of 12, so it's likely to be in the pons, which it is. And it's a mixed nerve, which means it has both a sensory portion and a motor portion, okay? So when we talk about the sensory portion, we have a particular ganglion called the Gasserian ganglion, which basically contains the pseudo-unipolar cells. If you remember what ganglion means by definition, it's just like a group of cell bodies of neurons or whatever. So these will give off their branches to the 3 sensory nuclei that you need to know in the trigeminal nerve. The first one is a principal sensory nuclei. So this is also known as the chief sensory nuclei, and this will give a sensation for touch and pressure of particular portions of the face, which we'll talk about later. And then we have the spinal tract or the spinal nucleus. So that controls, pain and temperature sensation, and that's found a bit lower, so where the medulla oblongata and the spinal cord is. And we also have the mesencephalic nucleus. So mesencephalon just means midbrain. So it's found in the midbrain, and it's responsible for the proprioception, so the awareness, the spatial awareness of the muscles that are responsible for chewing. So when you chew, this nucleus gives that sensation of sort of spatial awareness, knowing how to move your jaw in a particular coordinated fashion. Okay, we also of course have the motor sort of function as well, and that's for the, like I said, the masticatory muscles, the muscles which are responsible for chewing. So things like the masseter muscle, the pterygoid muscles, and a bunch of other muscles as well. And it's also responsible for the mandibular reflex, which we'll talk about later as well. So when we talk about the peripheral branches, so these are the branches that come out after these nucleus give off their branches, we have 3 divisions, okay? So we have V1, V2, and V3. V1 is ophthalmic, V2 is maxillary, and V3 is mandibular. And they come from 3 different holes or perforations or openings in the cranial fossa or the cranium, right? So the first one, V1, which is the ophthalmic division of the trigeminal nerve, comes from the superior orbital fissure. Now, you may think that's like an irrelevant fact, but actually, if you remember, at least ophthalmology, when we were learning it, you might remember that most of the structures which innervate the ocular, the ocular component of our face is actually go through the superior orbital fissure. So it makes sense that the ophthalmic division also goes through that, okay? Then we have the V2 division, which is applied. It's also known as the maxillary division, and it goes through the foramen rotundum. And then, if you know your anatomy, you know that the foramen ovale is posterior to the foramen rotundum. Therefore, the last one is mandibular. So it's the last number, V3, posterior to V2, basically. So the ophthalmic innervates the forehead, maxillary innervates sort of like the cheek area, sensation-wise, and mandibular innervates like the lower lip and the mandibular edges. And like I mentioned, we also have the spinal tract nucleus as well, which I talked about, and that actually comes from the cervical segments of the spinal cord, and they give sensation in a very particular fashion, and it's called like an onion ring or onion skin appearance, basically, like how an onion has like different layers, so it covers the different parts of the face in a particular onion skin fashion, and that's called Selder zones. Well, that's not too deep to sort of worry about. So in terms of a reflex component as well, reflexes are very important. A big reflex that we have as part of the trigeminal nerve is a corneal reflex, but it's a bit weird because the afferent part, which is the part going to the central part, so if you don't know what central part is, it's just the place where there's a synapse between one nerve and the other, in the brainstem or spinal cord, whatever. And so the afferent part, so the entering part, is actually by the trigeminal nerve, whereas the efferent part, the exiting nerves, are innervated by the facial nerve. So if you have an afferent lesion, which means basically if this trigeminal nerve gets mashed up, you're going to get absent coronary reflex, obviously, because there's no sensation to actually give off a response, which is basically, in order to actually do this coronary reflex, you're supposed to put a cotton wool on the corner of the eye, then the orbicularis oculi, which is supplied by the facial nerve, that will contract. So if you have no afferent pathway, you're not going to get a response. If we have a efferent lesion of the facial nerve here, if I'm going to make a video maybe on the cranial nerve number 7 soon, but this is basically known as Bell's palsy. Okay, so this is a lesion in the peripheral nerves. So basically, wherever there is a lesion of these, cranial nerve number 7 branches, the facial nerve, on that particular face. So let's say you had a lesion, an efferent lesion on the left side of your face, right? And I stimulated the right side of your face. Only the right side will blink because the facial nerves there are fine, but the left side, the bit where the lesion was, won't, it won't give you any blinking. Okay, so hopefully that makes sense, but it will be covered better in the cranial nerve number 5 topic. If I have time, I'll make a video on that. So the most important part, obviously, is the clinical examination. So first of all, look for general asymmetry. Look at both halves of the face, see if there's any sort of atrophy or whatever. Then if we have to measure it now we have to basically clinically examine it just like how the anatomy is. So let's look at the sensory part first. We should be testing for light touch, pinprick temperature, so on and so forth. So always link it back to the anatomy. So we're basically measuring or assessing these nuclei to see if those are in sort of good shape. So we can use a cotton wool or a pinprick, little, that sharp part of your reflex hammer, whatever. And we are testing for the specific divisions of V1, V2, V3. So V1, you put a cotton wool on the forehead, V2 in the cheeks, V3 in the lower lip. And also you might as well test for the coronary reflex as well. And then the motor part, which is basically for, the masseter, like I said, the mastication muscles. There is another reflex here, which is the mandibular reflex, which you basically get the patient to sort of half open their jaw a bit. You put your chin, or so you put your thumb over the chin, and you basically lightly, knock the hammer, and you should see like a jaw jerk. That is the expected response. But obviously, if there is a problem with the motor nerves, then there could be, for example, if there's a problem in like I said, the motor nerve, there's going to be the lateral pterygoid, which is one of the muscles that is responsible for chewing, right? That's going to basically shift towards the side which has been paralyzed. So there's a paralysis on this side, which innervates the motor muscles of the chewing. Then that means this muscle, which is intact and it's still fine, will push towards the parallel sides, because obviously this is still working, so it pushes it towards that side. So now let's talk about syndromes. All right, so this is things that happen if there's a problem with the trigeminal nerve. And the biggest one, so we can actually split syndromes into positive and negative. So positive means exaggerated things, or positive symptoms basically, and negative, which means reduced symptoms. So positive symptoms include trigeminal neuralgia, right? This is a really, really excruciating pain, and it's known as suicide disease because the pain is so bad it actually gets people to end themselves. So it normally happens, there's different causes, but normally one of the causes is a compression of the superior cerebellar artery, which is an artery in the pons, which compress against the cranial nerve number 5, the trigeminal nerve, and it can affect different parts of the divisions of the trigeminal nerve. All right, and then negative symptoms, just the opposite. So hypoesthesia, which basically means reduced sensation of the trigeminal nerve. And then we can also classify the syndromes of trigeminal nerve based on where the lesion actually is. So sensory wise, we should always link it back to the anatomy, all right? So if there's a lesion in the mesencephalic nucleus, if you remember, the mesencephalic nucleus was responsible for proprioception of the chewing muscles. So obviously, if you have a lesion there, you're going to have loss of that aspect, right? If you have a lesion in the chief sensory nucleus or the principal sensory nucleus, you're going to get loss of pressure and touch, basically, okay? And if you have a lesion in the spinal tract nucleus, you're going to get loss of the pain and the temperature sensation in the onion skin organization that I was talking about, the Selder zones. Also, the Gasserian ganglion, which I told you at the start what that is, which basically gives off the the axons and the bodies, whatever, to the nucleus. If there's a lesion central to the Gasserian ganglion, which basically means from the brain to that ganglion, right? Okay, you're going to get loss of all sensory functions, basically, because all the fibers are coming down to this ganglion. So obviously, if you have a lesion there, everything is basically mashed up. And if you have a peripheral lesion, okay, then it just depends on which part of the nerve did the lesion happen. It can happen in V1, and then you'd have loss of all sensation in that aspect, or maybe a lesion in V2, and so forth, so forth. And then if we can even have a lesion in the internal capsule, right? And this is responsible for bringing the connection from the brain, the cortex, to the peripheral branches. And you're going to get loss of sensation on the contralateral side, which I've shown here with this sort of dashed face on the L side when the lesion came from the right side, and that's because there's a decussation, so they cross over. So obviously, if there's a problem here, you're going to get loss of sensation on the opposite side of the face. Motor-wise, so this is just exactly like upper motor versus lower motor neuron. If you have a lesion in the supranuclear part, which basically means above the nucleus, before its synapses moves on to the motor muscles, the muscles and the motor nerves of those muscles, you're going to have upper motor neuron lesions. But it depends, because if you have a unilateral, which basically means on one half of the face, that supranuclear part is being damaged, nothing actually happens, because the cranial nerves, most of them, are bilaterally innervated. So even if one half gets affected, it still gets another sort of signal from the other side, so it's still fine. But if you have a bilateral, which basically means both sides are mashed up, you're not going to have any backup, basically, and then you're going to get symptoms of upper motor neuron, such as muscle wasting, but not atrophy, because atrophy happens in lower motor neuron lesions. And you're going to get an increased reflex. You know how in upper motor neuron lesions you get hyperreflex? So this is exactly the same thing. You get increased jaw jerk reflex. And then we have infranuclear lesions, so any lesion below the nucleus. Okay, and this is exactly like a lower motor neuron lesion. So you're going to get loss of sensation on that particular side of the face, so ipsilateral. So if it's on the left side and you have an infranuclear lesion, you're going to get a not loss of sensation, but loss of motor functions. Okay, so loss of motor function, so things like hyporeflexia, reduced jaw jerk reflex, and all that sort of stuff, atrophy of the jaw, the chewing muscles, and so forth, so on and so forth. But that is quite rare to see, really. But yeah, that was it, guys. So hopefully that was some sort of benefit to you guys.